Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right. So again, I welcome everyone for this class. And like I was telling you initially about the introduction, that this is a class on postmenopausal bleeding. But again, the spectrum is so huge, so vast that it can go both the sides of cervical carcinoma, finally, the final culmination point, and the endometrial carcinoma. So you have to prepare yourself up for both these important aspects. Okay. Right now, like I said, for simplicity's sake, we're taking only the spectrum till endometrial carcinoma, and that also I have a doubt how much we'll be able to cover just in one session alone. So the huge magnanimity of cervical carcinoma we'll be discussing under the heading of postcoital bleeding, hopefully next when another student takes up this particular case, right? So right now we are going to be discussing PMB, but in the light of endometrial hyperplasia, endometrial carcinoma, polyp, and so on, right? We will not be touching on cervical carcinoma. That being said, it's not a case which might not be asked in the examination, all right? So just remember that this can be absolutely on your examiner's point of view, and also upon your answers where the case shifts. So, but be prepared for a postmenopausal bleeding case to go either of these directions. All right. Right. So we have a student presenting up the case of a patient who is a postmenopausal female, and I'll just put it up for her to speak about what her case is. So I welcome Lavanya for the case tonight. Let's hear about the case from her point of view. Yes, Lavanya, you can speak.
Yes, ma'am. Good evening. Today I'm presenting a case on postmenopausal bleeding. So here my patient, Mrs. X, a 53 years old female, postmenopausal female, para 2 life 2, who belongs to lower middle class, came with complaint of spotting per vaginum on and off since 10 to 15 days. Um, History of presenting complaints. So she's having this complaint of spotting per vaginum on and off since 10 to 15 days. So it is not, there is no history of continuous bleeding per vaginum before, no history of any easy fatigability, weight loss, or loss of any appetite, no history of postcoital bleeding per vaginum, no history of excessive foul smelling discharge per vaginum before.
Okay. So here we were discussing earlier on regarding very important aspects. I asked her that she's postmenopausal since how long? So tell me, Lavanya, she's been postmenopausal since?
Ma'am, she is postmenopausal since 10 years.
10 years, okay.
Yes, ma'am.
And
So,
yeah, please tell me.
yes, ma'am. There is no history of any previous episode of bleeding or spotting PV before
Okay,
in
all
this
right.
10 years.
Okay. And what exactly, how do you club a patient becoming menopausal? What do you mean by menopause?
So, if there is a loss of menstruation or menstrual cycles for a period of 1 year,
Hmm. Yes, 1
then
year.
yes, ma'am. The definition that is called as menopause.
All right. And is there any significance of this patient having menopause 10 years back? Why did I ask you specifically how long back did she have a menopause? Is there any relevance of this question?
Yes, ma'am. If it is late menopause, there will be more exposure of estrogen in her, and there can be a lot of complications further. Uh, so this menopausal years, age of menopause, and since how long she is menopausal is a
Mhm.
very crucial history.
Right.
Yes,
And can we now
yes,
discuss about the negative histories that you put forth? Why did you ask about history of any continuous bleeding? What do you mean by that? Is this important?
yes. Yes, ma'am. If she is bleeding continuously since a few years, so uh, there can be a risk of and
Some
cancer
endometrial
prolonged
pathology.
staging. Yes,
No. Staging endometrial pathology could be any endometrial pathology. It could be
yes,
a
ma'am.
endometrial polyp. It could be a
Polyp or
hyperplastic endometrium,
hyperplasia.
or it could be endometrial carcinoma. See, girls, you
Yes,
have
ma'am.
to be very specific about what you are answering. Okay, don't get
Yes,
trapped into the language has to be so flowy that you cannot be trapped. So if you say some endometrial pathology, you are the best answer that you can give. Some
ma'am.
endometrial pathology, that means everything is included. If I ask you what all are you expecting, so continuous bleeding and specifically erratic, irregular breakthrough bleeding can happen in one of these pathologies, like I said, right? So it could be endometrial
Yes,
polyp. It's a very beautiful, what do I say, negative history to be written. There is no history of a similar episode anytime back, no history of irregular bleeding off and on before. It's just the first episode. Okay, so that
Yes.
tells us all that had it been a growing endometrial pathology, she would have had recurrent episode. But this is the first episode. That's very important. And why did you ask easy fatigability, weight loss, appetite?
Ma'am, to rule out any cachexia symptoms. Yes, ma'am.
To rule out all those things associated. These are all symptoms associated with the flourishing
Associated with them.
cancer, any cancer.
Yes,
Okay,
ma'am.
history
Any
of
cancer.
postpartum
Yes, ma'am.
bleeding. Let's say something to what is postpartum bleeding telling you?
Yes, ma'am. So there can be a localized lesions like
Yes,
cervical erosion, cervical polyp, or
growth, cervical
sorry,
growth.
growth.
Correct.
Yes, ma'am.
Most
Ulcer. Or, yes,
she was having spotting PV, but it's not
yes, ma'am.
associated with coitus. Okay, so there's no
Postpartum. Yes,
history of
ma'am.
postcoital bleeding PV, and there is no
Yes.
history of any excessive foul smelling discharge. Again,
False
a
smelling
local lesion,
distance.
right?
Yes, ma'am.
Okay. More history. Yeah, please help me.
There is no history of pain, abdomen, or fever, no history of multiple sex partners, no history of multiple genital infections, no history of hormone replacement therapy, no history of something coming out of vagina or increased frequency of micturition or urinary retention complaint. She is not on regular pap smear screening follow-up, no
Yes.
history of trauma, no history of dryness or itching per vaginum, no history of constipation or associated bleeding per rectum, no history of blood during urination.
Yes, all these are telling us all the lesions that we are possibly thinking. So whenever a patient comes to you with a postmenopausal bleeding, tell me the etiology that comes into your mind when a person comes to you with postmenopausal bleeding. And if she misses out any point, I'll be asking my students who are there very active in the chat box, who are very happy when the glitch was going on. I didn't see so many messages before as I saw at that time. So I want you all to write down here as well, correct? So yeah, please tell me the DD that comes into your mind when I talk about postmenopausal bleeding for your patient at that age, okay?
Yes, ma'am. So, postmenopausal bleeding, DDs can be atrophic endometritis or vaginitis, endometrial polyp, or any cervical lesions, cervical ulcer, cervical polyp, vaginal ulcer, or endometrial polyp, and
Did you say endometrial
endometrial,
hyperplasia?
yes, ma'am, endometrial hyperplasia,
Okay.
uh, yes, ma'am,
Anyone
or
anyone with any other DD in mind for her age, okay? 53 years of
uh,
age,
there can be
postmenopausal.
decubitus ulcer also in case of
She had that.
prolapse.
Yes, if she
Yes,
had a.
ma'am. If she had.
And a very important history she's asked. Very important history is that she's not on any hormonal replacement therapy. Very important because there are patients who are on hormonal replacement therapy, everything was going fine, suddenly they started having breakthrough bleeding. Or in between, they're having, usually it does not happen. It happens usually in the beginning or when you start taking the hormonal replacement therapy. But it can happen anytime if she's taking, unsupervised or not coming for regular follow-up, and she's slowly developing some local pathology. So HRT can also lead to sudden breakthrough bleeding. So that's a very important history. And the other very important relevant history is that she's never been through any pap smear. She's never had any pap smear, correct? So there's no follow-up. So
Yes,
we
ma'am.
never know if there are any precancerous lesions of the cervix and they've not been picked up and now they have started showing their symptoms. Uh, all
Yes, ma'am.
right. Okay. I'm getting the DD from everybody. See, very important when a patient comes to you with any complaint, okay, is the immediate DD in your mind. And then your history, your negative history, it starts building up on that particular. So if you must have seen that up till now, whichever cases I've taken, the moment the student tells me that this is the complaint with which the patient has come, I ask the DD there and then. It's very strange sometimes for the student that DD would come probably towards the end. But why I'm beginning is because your entire negative history will start from there. History at least will start from the examination will add on to it in probably narrowing the DD down. But your differential diagnosis should come at the very beginning. The history has been told to you. In fact, the presenting symptoms have been told to you, right? So very important is to know what are the most important presenting complaints and then start building a case from there. All right, we have some more differential diagnosis. So here I'd like to stop in and ask you, I think, yes, another very important aspect about associated bleeding PR. Sometimes what happens is that postmenopausal females, they also had these piles and everything, and they are confusing the bleeding PR with, bleeding PV, right? And they're very, very apprehensive. They come to you. So very few intelligent patients will be able to know the difference. They'll just say that some bleeding is there down below. I don't know. It's most probably coming from the vagina. So they'll never know. So this is very important to find out whether it happens only after you pass stools, before stools, after stools, that time when you're having constipation, or does it happen anytime, every time? That's a very important decision. All right. And why did we ask about pain, abdomen, fever, and all? Is there any relevance to this?
Yes, ma'am. If there is any um, cancer, ovarian tumor, or if
Uh,
there is,
Oh yeah, see, pain, abdomen, fever might not relate very well with our patient. Okay, so
yes,
you
ma'am.
can easily omit that history. Unnecessarily, you will be able to not justify your. And remember, guys,
Mm.
whenever you're not able to justify your negative history, just skip it. No one will, ask you anything else, especially in the negative history. Until unless you're missing out a very big point, right? So usually bloating, okay, abdominal distension are the associated
Yes.
symptoms with an abdominal mass, especially the ovarian mass. And ovarian mass at this particular age, when we're thinking about a postmenopausal female, would mostly be ovarian carcinoma, which will not probably be exhibiting as postmenopausal bleeding. It
So,
will be mostly, yeah, it will mostly be abdominal distension, like loss of appetite, or feeling of bloating all the time. These will be the typical complaints.